Dr. Michael Bohm from University of Saarland in Hamburg, Germany. Michael, welcome. And finally, Dr. Patrick Resignol from University of Lorraine in Nancy, France. Welcome. All clinicians, physicians, nurses, whoever, if you're taking care of patients, are really very well aware of acute severe hyperkalemia. We think about it, we worry about it, and perhaps are really up to date on how to manage that acute patient in the emergency room who's at really a high risk for some bad outcome in the imminent time frame. However, we perhaps don't give enough time in thinking to chronic hyperkalemia. There are patients with chronic kidney disease who are at risk for chronic hyperkalemia, but more so importantly are the patients who are at risk for chronic hyperkalemia. And the way we treat chronic hyperkalemia is we actually stop all the good medications that are important for their comorbidities. So in a way, the patients may not be hyperkalemic, but that is at a big expense of stopping important medications like RAAS inhibitors and mineralocorticoid receptor antagonists. So I think our lens today for our discussion would be management of chronic hyperkalemia, not necessarily just the acute phase of the disease. So in this program, we will discuss the epidemiology, some of the clinical considerations, and management options for these patients, especially the high-risk patients with heart failure and chronic kidney disease. So let me start with you, Ileana, with this sort of lens of looking at hyperkalemia, not necessarily as an acute, but as a chronic disease. Can you tell us a little bit about how prevalent this is and its specific relevance in specific patient populations?
It is incredibly relevant, and I think you said it very well. Everybody thinks about the acute effects, and we've all been taught about the arrhythmias that can happen with hyperkalemia, and I think that's what's on everybody's mind. My nephrology colleagues tell us that it's how slow or how fast that potassium goes up that they worry about. But my colleagues worry about it all the time. And it takes them to not give the right drugs because of the fear of hyperkalemia and maybe the fear of appropriate monitoring. And so the patients go without the drugs that we know. I mean, we've proven it time and time again, they work. So it's very, very common. And particularly the fact that our heart failure population nowadays has so many comorbidities, CKD being so common, and diabetics with CKD, who, in my population, have the highest prevalence and incidence of hyperkalemia.
And I think what's also sort of interesting is that every which way you look at it, the population is getting older. Your GFR with age curve tends to go down. These comorbidities tend to go up. And these are exactly the patients who actually need the therapies the most, who are at risk for development of hyperkalemia. So maybe, Michael, you can tell us a little bit about the risk of hyperkalemia with different therapies that we use for these comorbidities.
Yeah, indeed, there is, first of all, strong evidence that indeed a high potassium level goes along with a high mortality rate. And the biggest data set from this comes from the United States insurances, showing that indeed the best value is around 4.5 to 4.8. And they have all in common that then it becomes a U-shape or even L-shaped curves with a sharp increase in mortality when it comes to higher levels. And this is a database from insurances. They separate different populations. So the interesting thing is the optimal value is the same for all kinds of type of people with different comorbidities. But the problem is when it comes to age, diabetes, renal impairment, the curve gets steeper. So the inflection point is the same, but the curve gets steeper. So the risk added by hyperkalemia gets greater. And the other point is there is a registry now in heart failure patients where in particular these drugs are important to prolong life and reduce hospitalization. And in these patients, it has been shown that those starting with a low level and going to the high level, they have a poorer outcome than those who are become normokalemic over the time. And the important point here is that this shows that it's not just a marker of disease, but it is possibly modifiable, and therefore drugs can use it. And indeed, there are data generated by the group of Professor Rossignol showing in the RAAS studies and in studies in heart failure that the beneficial effect is not preventing hypokalemia, but in those drugs like spironolactone or eplerenone, there is a parallel shift to lower risk levels in patients with high and low potassium levels, but that on the other side means that the increase in risk at high potassium levels maintains, and it is still a problem in patients on these life-saving drugs.
So you actually mentioned a few very, very important things that I want to highlight for our audiences, that the benefit of MRA therapy in patients who develop mild hyperkalemia is still there. You still benefit, but nevertheless, at an absolute level, those people who are in the normal kalemic range are at a lower risk, even on therapy, than those who are on. But before we talk about definitions, let me just ask either of you, prevalence, what are we talking about? In general population, maybe patients with heart failure, is it a common problem? Are we making a big deal out of nothing?
I think the other way around is also true. You have a patient that's come in and getting diuresis because they decompensated, and now you're transitioning them to their chronic heart failure therapy. They may have been diuresed enough, and now they're hypokalemic.
Yeah.
And they're requiring potassium supplementation, which has always been to me a sign that they need more RAAS inhibition if they're still hypokalemic. And so that to me presents an opportunity to get the drugs up and an opportunity to start the mineralocorticoid antagonists, which I think are so critical.
Yeah, I mean, the data that really sort of impressed me was that, in general population, this may not be a big problem, 1%, 2%, 3%, something like that. But when you start talking about the target population where all these medications are needed, we are talking about 10, 15% heart failure, CKD. But by the time you start getting into advanced stages of CKD, we are looking at hyperkalemia incidence in some studies all the way up to 50%. And there, the interaction with the RAAS therapy is the most of developing the risk of hyperkalemia. I mean, one example that I always give is that Paradigm HF trial. If there was any patient population that should not develop hyperkalemia, that's Paradigm HF trial. So these are heart failure patients. Potassium baseline more than 5 excluded. GFR less than 30 excluded. And then there is a run-in phase, and anybody who developed hyperkalemia in the run-in phase excluded. So you're really trying to take up your population, and yet about 16, 17% of them in the middle of the trial developed hyperkalemia. So you can imagine if 1 in 5 or 6 of this patient population develop hyperkalemia, that in the real clinical practice it's probably far more common.
With sicker patients too.
Absolutely.
Right, and in the heart failure population, you can clearly see that in patients with stable heart failure, like in emphasis, there is an increased rate of hyperkalemia, but it is more strong in the RAAS trial with severe heart failure. And this is simply due to the increasing comorbidity load, in particular of renal failure in these patients. So then it really comes up to 15, 20%.
And you've also got
under trial conditions, which is always less than under real-world conditions, as is shown by registries.
And yet there's the dichotomy that they are also, these drugs, protective of the kidney, particularly the ACE and the ARB. So you're giving them as a protection, but at the same time you're getting the side effect of hyperkalemia.
So Patrick, let me ask you a very simple question. How do you define hyperkalemia?
Well, it is true there may be some inconsistency across medical specialties towards the way hyperkalemia may be defined. However, which is consistent across guidelines is that above 5, we should pay attention to serum potassium levels, and this may lead us to define what is a mild hyperkalemia, between 5 and 5.5, which is a moderate to severe hyperkalemia, above 5.5 or above 6.
So where do we worry about potassium? So more than 6, no argument, you worry about it. 5.5 to 6, do we worry? 5 to 5.5, do we worry? What do you think?
So worrying means a little bit concerned or panicked. Yeah. So and that depends, of course, as I said before, on the morbidity load, on the age of the patients, on renal function, and also on what is the sensitivity to hyperkalemia. In addition, with, for instance, other drugs like digoxin, there might be an increased toxicity. So as a cardiologist, one would look at the ECG first, and cardiologists always think of arrhythmias. I think we have a different perception than nephrologists at all. So I would at least see a patient who has been hypokalemic or definitely normokalemic and is now all of a sudden at 5.5. I would like to control it within the next day or the next few days at least, and also would try to pause but not get rid of any potassium retaining drugs And also, of course, diuretics are an option, and giving IV fluid. This is a possibility, but I think the crucial thing is to see the patient again and to see how he develops, and also rechecking the values is important, because all kinds of the way people take blood can modify potassium. I think that is something which is important for clinical practice.
And I also think that you need to get back to the patient and ask them, when I start to see that 5.5 and I start to get a little worried, what are you taking over the counter?
Sure.
And the non-steroidal, especially in the elderly, are famous for adding another burden now to the hyperkalemia. Plus, are they taking salt substitutes, which are sold right next to the salt, and the patients think, oh, I was told not to have salt and not to have sodium, I'm going to take a salt substitute. Unbeknownst to them, of course, it's potassium.
Yeah.
So we have a whole page in our book dedicated to potassium-containing foods, which now includes the potassium salts for salt substitute. I think you've got to do that. It's due diligence. I don't want to remove a drug simply because it's in a high potassium diet or non-steroidal environment.
I mean, I think the potassium level that sort of intrigues me the most is between 5 and 5.5. So if you look at it, more than 6, nobody would argue you need to treat it emergently. 5.5 to 6, maybe different specialties have a little bit different threshold, but again, nobody would argue that you can ignore 5.5 to 6. And by the way, sometimes we almost, the way we project cutting back on RAAS inhibitor as if this is not an optimal therapy. Remember, all the guidelines suggest that. I mean, that's good care. If you're at 5.5 to 6, the guidelines tell you to cut back on your ACE and ARBs and RNEs and MRAs. The reason 5 to 5.5 intrigues me the most is because that's where there is the biggest variability in how people perceive the risk. But now there are papers after papers after papers, granted observational studies that have consistently shown that U-shaped curve that you were talking about, that the risk actually starts going up after 5 and not 5.5. Now, the debate out there is what does that mean? And clearly, there are 3 different populations mixed in it. So I don't think at this point there is any doubt that the risk for mortality goes up over a potassium level of 5. So the question is why? So one is whether it is attributable to hyperkalemia. 2 is the patient phenotype, because the people who develop hyperkalemia have more comorbidity, diabetes, etc. But the third part, which is the most intriguing to me, is how much of medical therapy you have compromised that has led to progression of the disease. And that's where the biggest irony is, that if somebody dies of worsening heart failure or worsening CKD on no medical therapy, you will never trace back and blame hyperkalemia as the cause. You will just say this is worsening heart failure, but you have actually compromised the medical therapy.
They become ACE intolerant as they get sicker. So
Correct. Correct. So Patrick, can we predict hyperkalemia? Does it always come as a surprise? Can you prepare for it?
Yes, no doubt that we may be prepared to it, and there are some initiatives, for instance, the SCREAM project developed in Sweden, which led to develop a risk score, which does include both potassium at baseline, but also gender, EGFR, diabetes present or absent, heart failure, the intake of potassium-sparing diuretics, which may lead to raise awareness towards the risk of developing hyperkalemia within a year, should you be prescribed RAAS. And for instance, there are several scenarios. It's totally different. Should you be a man with an EGFR, let's say at 55, with diabetes, depending on the presence of absence of heart failure or potassium-sparing diuretics. This may lead to a 6-fold increased rate of hyperkalemia within a year. Thus, should we be willing to consider such a risk score, this may raise awareness towards the need to properly monitor potassium after the prescription of RAAS.
So this is sort of really interesting, and if there are these prediction models that you're talking about, that opens a whole new door to prevention of hyperkalemia. I don't think we're there just yet. These data are emerging, but clearly opens up the opportunity. But because of the consequences of hyperkalemia, both the real consequences, which is arrhythmic risk or other, and also don't underestimate the perceived risk by physicians and nurses. If you're really worried about it, sometimes, 4.8 in a person with GFR of 35 seems like 5.5.
Well,
so,
you're already predicting it's going to get higher no matter what you do.
So is there, can you give us, Patrick, some general idea of what the guidelines are in terms of monitoring hyperkalemia when you give RAAS inhibitor therapy?
Actually, it is clearly stated across nephrology, cardiology guidelines that potassium, but also creatinine, should be monitored properly, which may mean that before prescribing a RAAS, we need to get potassium creatinine measured. We need to measure them shortly after the prescription, let's say within a week or within 10 days, depending on the guidelines, at regular intervals thereafter, monthly, let's say, something like that, or within 3 months. But registry data, unfortunately, shows that it is rarely the case. The US registry shows that less than a third of patients are getting monitored properly. And more recently, Swedish registry data shows that less than 23% of the heart failure patients got properly monitored. Therefore, there may be some hurdles, and it's still a long way to go. We need to educate our colleagues more to raise awareness on the need to properly monitor potassium.
So, Liana, I mean, measure potassium in a week with ACE inhibitor, or even 3 days after initiating MRA therapy, follow back up in a week, and then on a monthly basis for 3 months, and all these kind of guidelines that have come because of some of the papers that were published, that if you don't do close monitoring, there are some real risks with these therapies. The fact that most of the time people are not following this guideline, is it just because people are not aware of the guideline, or is it just really difficult to follow?
I think it's harder than what we realize. If I send a patient home, I may get labs, I may see them within 7 to 10 days, and I always try to get the labs before, but that's another visit then.
Sure.
And some of these patients already have 4 or 5 visits scheduled. I'm adding one more for that extra lab. Because the day I see them, I can send them down to the lab, but then that means I won't get it for another day. So I can't make any adjustments. I've even tried using the home care nurses, which are wonderful, to get the blood, but if they're not in the same system, I don't see it. I don't see that this happened this week. I don't see the lab. Not that simple.
So it's complicated, it's burdensome of the patient, and it's not only burdensome on the patient. Somebody live far away. Mm-hmm. Most of these patients are older patients, so they may have some family caregiver to bring them and all that kind of stuff. But also remember that, physician practices are full, so opening up new spots and whatnot. So it becomes a little bit more complicated. So the guidelines say if you develop hyperkalemia to cut back on RAAS inhibitor therapy. In real life, close monitoring is very difficult. So what's wrong with it? So if you have a heart failure, diabetes, CKD patient, why not just stop ACE, ARB, MRA, and just forget about it?
I am such a believer in the drugs and in the trials that have been done that are so positive that I want to give my patients the opportunity to get the very best and to get the very cutting edge. So if I have to, see them again quickly just for a quick checkup and make sure that their potassium's okay, I'll do it. But I can also try to prevent it if I think it's going to happen by treating the hyperkalemia.
Yeah, I mean, it all sort of boils down to, at the end of the day, these drugs are class 1 indication. There are clinical trials after clinical trials, randomized large trials showing significant benefit with these therapies. With MRA and the RAAS trial, there was a 30% reduction in mortality risk. With all these, latest trials with ARNI, 20% cardiovascular mortality reduction, ACE inhibitor ARBs. I mean, these are some real benefits we're talking about, and just stopping the medication. Again, if you have no option, that's okay. I guess that's what you have to do. Safety first. But I just want to emphasize to our audiences that this just come at a price. So let me just push you a little bit more, because we have had many discussions before, and I know what your feeling is towards this. Why not just give some very, very tiny doses and forget about pushing the doses?
Yeah, it's actually very hard to get like 12.5 of spironolactone. I end up having to find the liquid, which not all the pharmacies carry. Our pharmacy doesn't like it. Then I have to say to the patient, well, how about every other day? Does that work? Patients don't remember drugs every other day. They come out of the hospital with 13 medications. How can you take 13 medications? And now I'm going to tell them one is every other day. So I'd rather deal with the potassium and deal with it up front.
Yeah, and again, we at least have 2 large randomized controlled trials with ACE and ARB showing that going from low dose to high dose, there's about a 10 to 15% cardiovascular mortality, heart failure hospitalization benefit. So not only is it important to give the drugs, it is also important to maximize the doses if you possibly can. Now, realizing that people don't go on maximum doses for multiple reasons. Blood pressure is one, worsening creatinine is another. But at least the proportion that don't go primarily because of hyperkalemia, we can hopefully try to optimize that.
And how they will never be up-titrated because of the fear of hyperkalemia.
I cannot overemphasize what you're saying, is that it's not always a potassium of 6. There's a lot of potassium of 4.8s in the world, where there's just this inertia that if you do this, and then people were coming in. Then also there's this one strike and you're out. So you mentioned this issue of non-steroidals. Boy, there are so many patients who develop hyperkalemia once, where there's a clearly identifiable other reason. But guess what? You stop the medicine, you're not going there again.
That's right, but you have to take a good history to figure that one out.
Absolutely. So Michael, Ileana strongly recommends that patients with these comorbidities should be not only on RAAS inhibitors, either ACE, ARB, ARNI, or MRA, but also should be on good doses if possible. How do you do that in patients with hyperkalemia? Any advances, any options, any ideas?
Yeah, so I think we are clear about this and we agree upon that. High doses, not interrupting the therapy, which again could create adverse effects, whatever. So the vision is to have a combination with these life-saving drugs to maintain the potassium at a low level, to prevent but also to effectively treat hyperkalemia. And the classical drug is SPS, and every physician who has used it a lot tries to stay away from this because it has a lot of side effects, and it could create even perforations of the bowel, which leads to life-threatening effects. So my take on this would be that no patients would take this as a long-term therapy in order to make patients better accessible for the life-saving drugs. However, there are 2 new developments. One is sodium zirconium silicate, and the other one is Patiromer, 2 drugs with a better profile on tolerability. Both indeed bind potassium, where the concentration gradient between these structures and the potassium is very high in the gastrointestinal tract, and this is the colon. So they bind potassium, and then it is excreted with the feces. So with Patiromer, there are studies showing that there is, in patients on RAAS inhibition with different degrees of chronic kidney disease, there is a rapid fall in potassium once they have been treated with Patiromer. So in one day, the next day, you clearly see that the potassium goes significantly down. It is most of the time normalized. And then these trials, they indeed showed that it is possible to maintain these RAAS therapies, and that potassium level stays down. And when you then get rid of Patiromer, then it goes up again. And these trials have names of all these precious stones like opal and amethyst, pearl, and several others. So there is clear evidence that potassium hyperkalemia is treatable, that potassium stays low when treatment is maintained, and also the relapse rate of high potassium when you get out with Patiromer is strongly increased. So they have the potential to prevent hyperkalemia. And there is indeed one trial specifically in the heart failure population, and this is a PEARL trial, looking in patients on the possibility to treat them with an aldosterone antagonist with Patiromer, and indeed there was a higher intensity treatment and a rather long-term treatment. And now there is in Germany a small study which also is done in patients who developed hyperkalemia on a RAAS, in particular a mineralocorticoid antagonist, and then that is maintained and even increased. And we will see, beside some of the clinical endpoints which are captured, although it's not powered for that, we will see whether we can achieve a higher intensity treatment and whether we can maintain people on the drug. So one important point I would like to make at the end is this is not a treatment of a side effect with another drug. So we treat not a drug with another drug. But this is something like an enabling therapy, and this is something like a supportive therapy, as we know in many cancer therapies with antiemetics, where the therapy is only possible indeed when we avoid one of these life-threatening complications, which is hyperkalemia. And therefore, I think this is a great step forward, and this needs to be tested also in prospective trials.
I think it's important to talk to the patients about what you're doing, because I make it very clear to them that they can't just stop it without calling us. If they have a problem, they need to call us before they stop it, because I'm afraid if they do that to cut the drug and not take away the spironolactone, that the potassium could eventually in 12 hours, whatever, go up. So it requires good patient education, like everything else that we do.
Sure.
Of having them not stop the combination.
So to summarize the Patiromer experience in different trials that you just mentioned, so it lowers potassium, it lowers hyperkalemia into normal kalemic range pretty effectively. There are data extending all the way up to 1 year, so it maintains potassium. But the other thing that you mentioned that I also want to highlight is that the patient phenotype that develops hyperkalemia doesn't change. So if you stop it even after a year, the potassium levels go up. So we have to sort of maintain that. And then there are data with Patiromer also in better ability to optimize the MRA therapy, the mineralocorticoid receptor antagonist. Any studies that you know of with the other agent, sodium zirconium cyclosilicate?
There is another study with a new drug, which was recently, as I learned, is approved in the United States. Again, patients on RAAS inhibitors have a long-term follow-up for 1 year, and principally the same thing has been shown, that it enables these treatments with RAAS, and also there is a drop in potassium, and potassium stays down in the long run. So this is another study in more than 700 patients. So there are indeed also a couple of a quite big number of patients have been treated with either of the compounds, and so it's, I think, meanwhile, a good set of reassurance.
So Patrick, Michael started with this discussion by saying that the problem with SBS is it's just not tolerated. So these two new agents, sodium zirconium cyclosilicate and Patiromer, what is their tolerability? Now we have data for a year with both of these agents.
Yeah, in terms of tolerability, no doubt that these two compounds are safe. Firstly, they were both approved by the FDA and EMA. And in terms of tolerability, I would say that there are mild GI effects for both of them. For Patiromer, it should be noticed that hypomagnesemia may happen, but it may concern less 1% of the patients overall. As far as ZS is concerned, edema may happen, which may warrant a proper monitoring, I guess. We should notice that Localma is exchanging sodium versus potassium. So therefore, it is stated in the EU level that it may happen up to 10% of the patients. So these are well-tolerated agents on the long run, which warrant proper monitoring as well.
In my experience, Javed, the Patiromer sometimes gives constipation. So now when I use it, I tell the patients, you may get constipated. If you do, let us know. You know, we can always give a stool softener or a laxative.
Sure. So, I mean, the whole premise of coming up with these new therapies is to enable RAAS inhibition, MRA, ACE, So in these long-term data with both of these agents, with Patiromer and with sodium zirconium cyclosilicate, do you necessarily have to stop RAAS inhibitor therapy to maintain normal kalemia, or can you give these agents and also use the RAAS inhibitor and still be able to maintain normal kalemia?
As far as Patiromer is concerned, the OPEL-HK trial encompassed two phases. During the second phase, there was a placebo comparison versus Patiromer, and a clear demonstration that under Patiromer, a much higher proportion of patients get persistence maintenance of RAAS compared to placebo. Furthermore, drug titrations were very less frequent in those patients receiving Patiromer compared to placebo.
And I think even in these long-term, sort of the 52-week studies with both of these agents, they were really in the real life setting, so the physicians can do whatever, and majority of these patients were actually maintained on RAS inhibitor therapy with either MRA or.
You should also address that there wasn't hypokalemia.
Yeah.
Because that may be the other fear if we talk about the curve that you mentioned. Hypokalemia can be as high in mortality as hyperkalemia when you're outside of that sweet spot, but that the agents really don't drop potassium below 4.
So, Liana, you're a busy clinician. We're talking about data, latest and greatest, some of them even that they have been just presented, they haven't even been published. So bottom line is that these data have not been translated into guidelines just yet. So how do you manage your patients now?
Right, so what I do is I always start the ACE RNA first, and then I watch the potassium. And if I see that potassium going up and it's getting close to that 5.2 that I start to want to look at it, I start the Patiromer early. And I say to the patients, you'll take this for the first 24 hours, then I'll add the spironolactone. But of course, I'm going to see them. Sometimes I'll see them in 48 hours if I'm really concerned. So I think what we need to say to our audience is you've got to monitor the potassium. You just can't let it go. You have to do it, whether you do it at 3 days or at a week, but you've got to do it. And a patient that you think is not going to come back or lives far away and they're not going to get the potassium checked, maybe it's better not to do it.
And how do you, in patients with high risk for hyperkalemia or those with demonstrated hyperkalemia, decide to use any of these new agents?
I've had some patients on now over a year,
Wow.
on both, who are doing well and out of the hospital. Obviously, it's, totally our practice, but that's what our experience has been.
Yeah, and I think that's sort of the whole promise, right? So now you have clinical trials targeting up titration of MRA therapy with Pearl-HF, and then you have these long-term data that these therapies can be maintained, and that's sort of the main promise, is that you can enable therapy, and I'm sure that there are more trials and data coming. So any final words of wisdom?
Talk to the patients. What a wisdom, right? Talk to the patients.
Dietary counseling is something we haven't addressed. I think that is part of that.
Yeah. Conversation.
What I would say is please pay attention to potassium when you are prescribing life-saving drugs.
Great. Well, thank you very much for watching our program. We took a 360 look at hyperkalemia as a chronic disease. We discussed some of the epidemiologic aspects, pathophysiology, the risk with RAS inhibitor therapy, and the things that really jumped at me was the fact that a lot of these patients develop hyperkalemia who are also in the greatest need for RAS inhibitor therapy. Up until now, there were really no good options to manage these patients, but to stop life-saving therapies, but that resulted on one hand in lowering an acute risk of hyperkalemic complication, but bargaining that a bad bargain for higher risk of chronic worsening of these comorbidities. And now with these two agents that are available and approved, Patiromer and sodium zirconium cyclosilicate, we have the option to treat these patients more aggressively with their RAS inhibitor therapy, and I'm sure more studies and more data will be forthcoming, and we will hear some things in the guidelines as well. Well, Liliana, Michael, Patrick, very, very nice to have this chat with you. Thank you very much.
Thank you for having me.
And thank you for participating in this activity as well. Please continue on to answer the questions that follow and complete the evaluation.